to honesty with the patient, and commitment to a just distribution of finite resources that we have. So I talked about the multiple biases that we go through in our medical profession, and if we understand that we become the master of the mind and not a slave to our mind, then we probably have a solution for our medical problems that we deal with. So that's the point about being mindfulness in medicine. Thank you.
Pandav.
Before I start, thank you, Dr. Vinay, for inclusion into your program. When we set out to treat glaucoma, I think we basically set a target IOP because now here we are talking about the pressure which is high, and that's why we want to treat. So the target range of acceptable IOPs where your progression is unlikely to happen is what the target IOP. So I won't be going to the details, but anytime there's a inability to achieve target IOP, you kind of will change therapy. It could be escalation of medical management, or in some cases switching over to laser or to surgery. There are many ways of assessing target IOP, and I'm not going into those details, but anytime the IOP is uncontrolled, that basically means that the target IOP is not achieved that you have set for that particular patient, and that would be an indication for surgery in many cases. So the most common indication for surgery would be a high pressure. It's a high for that particular patient, as decided based on the history. So I'll just show you a couple of cases where we had high pressures and we had to do surgery. So this is 57-year-old male, primary open angle glaucoma, both eyes, 618 vision, and you can see the pressure is 20, but with a lot of medications. So, and you have a field which is quite cupped, and there's a neuropathy which is quite advanced, and the visual field is also is just close to the center. So this is an advanced disease, and it was deemed that like 20 millimeters of mercury pressure with all these medicines probably is not enough for this patient. And also you look at the previous history of the patient, how it is progressing, and this is the time when probably you need to reduce the pressure lowering. So we did trabeculectomy with mitomycin C in this patient, and we had pressure of 12 to 14 millimeters of mercury at 3 months. Now, problem here is that surgery is also not very, it's not a complication-free. So you have to keep in mind that proper counseling has to be done before you undertake surgery. You have to avoid adrenaline in perivalvular block because they are compromised nerves. Avoid sudden decompression. Try to maintain as far as possible anterior chamber, and also use tight closure as something which can be released postoperatively to control IOP. So this is another example, case 2, the 35-year-old female, the blurring of vision, 3 months and presented with a high IOP. So vision is already counting fingers, and the pressure is 50 millimeters of mercury. But if you look at careful clinical examination, you can see there's some synechiae already forming, and you also have some KPs there. So I think here the careful clinical examination would point you towards the problem, and before you decide what you want to do, you have to take care of the other associated conditions as well. So gonioscopy again shows there's a 360-degree angle closure, multiple broad synechiae, and also there's a possible neovascularization in the angle there. So you investigate this patient further down what is happening, and we had some vascular occlusion there. So the clinical impression overall after the investigation was that we are dealing with a secondary angle closure, and you have glaucoma because of granulomatous uveitis, and there's a CRV, and possibly there could be an NVG in this patient. So you treat accordingly, treat for the uveitis, do laser for the posterior segment, use anti-glaucoma medicines, and repeat gonioscopy shows that neovascularization has actually disappeared, so that may not be much of a concern. The IOP has come down at this stage, but subsequently the IOP rose again. So you have to keep these patients on follow-up, and then once the pressure is really high, even with all these medications, finally we did trabeculectomy for this patient with the appropriate adjuvant. So here the point to remember is that we have to treat the basic pathology first with the UVIT or CRVO. If required, you have to do laser or give steroids or stop steroids, and also some of these patients would need some adjuvants for glaucoma surgery. This is another case to illustrate the case where the pressures were high. 28-year-old male presented with severe VKC and had advanced disc damage. Now you can see there's a lot of inflammation in the lid, and for that the patient was on steroids for a long time, and also pressure was high and on a number of topical as well as anti-glaucoma medicines. So two are actually, acting against each other. So the first thing is to do here is to stop your steroids and give some time for the patient, the IOP to come down. But if the patient, the IOP doesn't come down, then you might have to escalate medical treatment or resort to surgery. So in this patient, after waiting for a couple of months, the patient was still high. The visual fields were showing deterioration, so we have to do trabeculectomy with mitomycin C here again. So you can see the disc is quite damaged. So the message here is that you try to remove the cause of the high pressure whenever it is known is a secondary cause, uveitis or steroids. Give time for the eye to recover before you go on to surgery. And if IOP is still high, if much beyond your target IOP, then we'll have to do IOP. And then we might have to do glaucoma filtering surgery without waiting for too long. So another case where we have a 37-year-old unilateral raised IOP, and the pressure is quite high. Again, if you look at it, it's like 52 millimeters of mercury with a lot of medicines. And gonioscopy is quite peculiar. It's showing a lot of adhesions within the iris, and cornea is not the typical angle closure disease, but there are a lot of processes and a lot of adhesions. And also you can see here, iris is not really distorted at this point of time, but you could see actually some adhesions in the periphery. So you look more carefully at this patient, and the disc is, apparently it looks normal, but if you look more carefully, there's a nerve-fibular defect here and some thinning here, and something similar is happening here, but visual field is also showing a change. So this is, going by this visual field, this is an early glaucoma, so can potentially be treated with medicals or laser, but medical therapy was not really working here. And when we did a little more investigation, this patient, why the medical therapy is not working, so we found on spectral microscopy that the patient actually had an ICE syndrome. And once we know that ICE syndrome patient, they do not behave very well, they may not be controlled well with the therapy. So we decided for early surgery in this patient. So here we have an early glaucoma, and where we did surgery because the pressure was not getting controlled. So here's IOP. If it's beyond physical limits and the nature of the course of disease or the diagnosis is such that is unlikely to respond to medical treatment, then early surgical therapy could be instituted. And then you have a condition where, sometimes the IOP can be controlled with drugs, but patients are allergic to multiple drugs. Now, these two patients are actually allergic to almost all anti-glaucoma drugs, even if their pressures were getting controlled with these medicines. So we decided to early surgery for these medicines rather than continuing with the drugs. So sometimes even if the IOP is controlled with medicines, but patients cannot take medicines, those are the patients where you have to offer alternative therapy. It could be laser, it could be surgery. And this is another interesting patient. We saw a 41-year-old female patient diagnosed glaucoma. It was angle closure glaucoma, actually, and maximum medical IOP recorded elsewhere was like 52 millimeters of mercury. And she also received mannitol on few occasions just to control her pressure because the IOP was really going high. And on examination, you can see the right eye pressure is still very high, though the vision is still good. And this is how it looks like. The entire is kind of a staphylomatous eye. So we did a laser eye dot with both eyes because the other eye also angles were narrow. We worked up the systemic uveitis workup and looked at are there any systemic features. She was on steroids for her for her scleritis, so she was being treated for scleritis. So we took her off steroids, gave her systemic immunosuppression, and waited for a few months, but the IOP won't come down. Now the problem is, what surgery would you do in this eye, because this is a whole staphylomatous eye, and this is a UBM again, which shows that this is still a bit of fluid there, and sclera is also it's not thin, but it's also not normal. It's kind of spongy kind of sclera there. So how will you manage this patient? So probably best bet would be a surgery. Again, word surgery would be good here. Trabeculectomy in that high, in the superior quadrant, would be very hard to do and prone to complications. And also, inferior trabs are usually should not be done because they're more at more risk of having postoperative endophthalmitis, especially if you're using mitomycin C. So in this eye, we put a drainage device. And I have this, just a little video. Can I run the video, please? So basically, because here the sclera is very thin, and you have to be very careful in dissecting this area. UVM had shown that this area is staphylomatous, but the sclera is not very thin. And what happens is that usually there is beyond the line of insertion of the muscles, in most cases you will find a normal sclera where you could suture an implant. So implant probably would be a better option, primary implant in this case, because of this area you can't really do any surgery, but beyond the insertion line of muscles you could do some surgery, and successfully you could put an implant there. So I'll pause for this video a little bit. Now, this is actually a little bit difficult. You have to be careful here because if the sclera is inflamed or has been inflamed in the past, it can cheese wire very easily, and the support for tube may not be very good. So you have to be very careful at this step and put a good patch graft over it to cover the tube. Otherwise, there could be tube erosion or migration. And this is how it looks post-operatively. 10 days later, and this is about 3 months later. The IOP is quite good at 14 millimeters of mercury with single drug. To summary, uncontrolled IOP is a commonest indication for surgery. Timing of surgery has to be individualized. There's no one formula that works. So you have to look at the visual fields, you have to look at the response to therapy progression and the ability of the patient to take drugs, and then individualize the timing as well as the type of the surgery you want to do. The important thing is that you have to prepare the patient beforehand, tell all the pros and cons of medical therapy as well as surgery, because surgery is not, kind of a complication-free. So mentally, you have to prepare the patient for whatever decision or the choice you make, and it has to be a kind of a two-way process, a participative, not one-way process that, okay, I want to do surgery. And the choice of procedure, as I mentioned, again, has to be considered carefully. Thank you very much.
Thank you very much, Dr. Pandav. I think you've given a lot of insights in this talk, and there are going to be about 20 minutes to ask questions at the end of the session. So may I please ask the audience to just keep a note of whatever they'd like to ask. Thank you very much. May I have you join you here, Surinder? The next talk is by Dr. Shushmita Kaushik, and her topic is, I operated because the patient showed deterioration in visual fields.
Good morning, and thank you, Dr. Vinay, for having me on the course. So we've just seen the indications which are commonly there for surgery, and this is a little bit of an unusual indication, so I really looked at why progression is important and how many times you really do surgery for that. So we know that glaucoma is a potentially blinding disease, and in an interesting publication, the fear of blindness was the first concern in nearly 1/3 of newly diagnosed glaucoma in the initial glaucoma treatment study. So when you tell a patient you have glaucoma, be very, very careful, because the first thing he's going to go back and Google and say that he's going to probably become blind. So stabilizing visual field loss is your objective method to assess visual function, and trabeculectomy is often performed on those patients with glaucoma who are deteriorating on fields. But then what do we know about the effect of glaucoma surgery on trabeculectomy? Is it such a good thing to do, and does it really make a difference? So I just scanned through recent literature. Interestingly, filtration surgery was done in eyes with progressive NTG, and the average post-op MD slope and pattern SD improved compared with preoperative slope. So obviously, surgery did something to make the downward slope better. Then there is evidence that the rate of progression of visual fields after glaucoma surgery, each 1 millimeter, translates to about minus 0.1 decibels per year decrease in the global rate. So every millimeter that you lower surgically apparently decreases the rate of progression by about 0.1 decibels per year. Then another one showed that amongst eyes with preoperative visual field progression, which is the one that we are talking about, the postoperative slope significantly reduced compared to the preoperative. So they all said that if you do surgery, the slope of the progression or the rate of progression, they're never going to get back to normal, but the rate of progression, if you do surgery, appears to be better than what it was prior to surgery. But then how much lowering? So there's one study which did a post-op period evaluation, and they found that the mean IOP was significantly higher in patients with visual field progression than in those with stable fields. That was one. And the other thing, that the mean percentage reduction of IOP was less in patients with progression than in those with stable fields. In other words, even post-operatively, those patients who had lower pressure, that's intuitive, did better or progressed less than those who had higher pressures, even in the post-op period. So it's not just doing the surgery per se. That means that it is lowering the pressure to a level where progression would not occur. So why this happens? One is IOP fluctuation is an important risk factor, and it is known that trabeculectomy or whatever glaucoma surgery, it dampens the fluctuation. But interestingly, the IOP fluctuation was not found to be important in those with high pressure. So this was more a low pressure sort of glaucoma thing. So if you want to interpret this clinically, if you have normal tension glaucoma or you have a person with glaucoma in the lower IOP ranges with fluctuation, those are the ones where trabeculectomy is likely to be of benefit, rather than those with high pressures and fluctuation where trabeculectomy doesn't seem to matter as much. And then there is a report that there is an effect of trabeculectomy on retrobulbar circulation and visual field progression. So the mean deviation slope in the operated eyes was significantly slower than the non-operated again. And the retrobulbar circulation, which they saw with color Doppler, increased. So they thought probably the reason for a slower rate of progression is that doing surgery and lowering the pressure improves the retrobulbar circulation to the optic nerve head, improving perfusion. So maybe that's the reason why it happens. Now, as Dr. Pandav has shown, when do we operate? The commonest indication is when the IOP is uncontrolled on maximum tolerated medical treatment, no matter what that IOP is. So obviously you've given everything, and the pressure that you've got, not necessarily non-effective. If you have a pressure of 40 and you can bring it down to 24, your medications are effective, but 24 pressure is simply not enough. So that's the commonest indication for why we operate, and of course severe intolerance to anti-glaucoma medications. But what about visual field progression? And this is like medications well tolerated, pressures okay, and yet the progression is happening. Now in that scenario, in our clinic, I really tried to fish out data as to what information do we have in the real world. One was scoring literature, but what do we do? So there were two theses that has happened. One is on functional and structural progression for largely early glaucomas, and one is a thesis of the outcome of advanced glaucoma patients who come with advanced glaucomas at presentation, which means glaucomas worse than minus 12 decibels when we see them first, which is a large part of our practice as well. So in the first one, I'll just share a little bit of this. The structural and functional progression was seen in 63 glaucoma suspects and 59 glaucoma patients, but they were all better than 12 decibels, which means they were all moderate or early glaucoma. So this was a progression in the early ones because we were looking at imaging versus functional visual field. And the mean follow-up period was about 6 years, and we assessed it by GPA visual field, a VFI, which is a trend analysis, and the OCT GPA. So it's a very crowded slide, but I'd just like to go through that slightly more, not very much different, slightly older age. This is by GPA, which is the commonest thing that we do on the visual field to assess progression. Pressures a little higher, cornea a little thinner, the mean deviation a little less at presentation, and obviously the rate of progression per year much more in those who progressed. But if you just look at this, just 5 out of those 59 actually progressed over a 5-year period. And when we looked at visual field index or the trend analysis, which is what most studies or reports talk about, because they say the slope is far more important than an event analysis. The GPA, remember, looks at today's event compared to a baseline, but a visual field looks at slope over a period of time. So it takes care of a bad day that a patient might have had or an outlier, because it gives you a general slope of what has happened. And here there was really not much difference in any parameter between the progressors and the non-progressors, at least functionally where early glaucomas were concerned. And whereas the outcome of patients presenting with advanced glaucoma, now she pulled out 119 eyes of 87 patients and 32 were bilateral, which means almost 1/3 were bilateral with a mean follow-up about 9. The minimum was 5, but the mean follow-up was 9.2 years. And the mean age was about 56 with a preponderance of male. 78%, more than 3/4 were male. 59% were POAG, 32%, about 1/3 were primary angle closure disease, and 7.6%. So those with advanced glaucomas, at least in our clinic, a majority were primary glaucomas with a very, very small number which was secondary. Now at presentation, if you saw, all of them, the visual acuity, because that was the main thing that the patient was concerned about, was about 0.22, which is about 618, and it went down to 0.32, which is about 624. These are logMAR units. The IOP at presentation was about 19.6 plus minus 9.5. So large fluctuation. We had patients with advanced glaucoma with as little pressures as 12 or 13. We had patients with 30s as well. But at last follow-up, the fluctuation was much less, at about 4, and with a mean of about 14. 55% were treated on topical medication alone. 5.9% required systemic acetazolamide at presentation, and 16.8% had actually undergone a trabeculectomy or a glaucoma surgery elsewhere when they came to us. But interestingly, when we looked at visual field progression, which is what we are talking about today, minus 20 at presentation was just minus 21.4 at the end of 9 years. So the indication for all these patients was IOP. The indication in none of them was a visual field progression. So my point is that it is the IOP which we treat, and if you treat the IOP logically and with common sense compared to your disc, even the advanced glaucomas apparently can be salvaged. There's not too much that goes on. But 41%, a little less than half, required glaucoma surgery at the first visit. The patient came to us and the first thing we decided was surgery. So it's important when they come, we don't even wait for visual field progressions or anything of the sort. If you have advanced glaucomas, they just land up getting surgery done. The second surgery was required in fact 1/5. 22% required second surgeries, and a third, in fact, in a very small percentage, about 3% of the eyes. So to confess, when I looked and searched, I found one patient who I operated because of progressive field loss alone, where pressures were okay for him and he was tolerating medication. So it's a very small percentage where it'll be that medications are also well tolerated, pressures are also all right, but the field is progressing. There has to be a reason why the field progresses. They usually don't. If there's compliance and if they're putting their drops in and if they're tolerating it and if the pressures are clinically, commonsensically what the disc warrants, then mostly they will not. But there was this gentleman, POAG, 23 and 34 on presentation. 14 and 18, he came down on 2 drugs. It was fluctuant in the left eye on diurnal variation. But by 2014, the VFI showed a definite downward slope. There was a wide fluctuation, 18 to 28 millimeters in the diurnals, and the visual field started progressing. And then when we saw possible progression, repeated many times, he's not a very good fielder. You can see the outliers, they go up and down, so we weren't really sure as to what the glaucoma was doing to him. The right eye remained stable. The IOP remained 15 to 17 on 3 drugs. With fields like this, a mid-teen pressure is not too bad. But by Feb 2016, in fact just this month, his IOP was 21 on 3 drugs. The visual field had actually reverted. It wasn't progressing anymore. So he suddenly had a very good day. And it came right back. But then he's on sustained release acetazolamide, and he is scheduled for a left trabeculectomy in March, because I can't really carry on with this fluctuation which goes on with his visual field. So probably he's the one who has been planned. But this is after about a year of trying our very best to figure out whether or not he's progressing or not. And the last visit now, but that was last year, sorry. Last visit in Jan, his pressures were 14, his bleb was functioning. Again, he was possible progression on GPA, and the visual VFI slope is not progressing. So now he's progressing again despite the surgery. So now what do you do? This plan is to repeat the visual field and just keep under close watch. So to summarize, it's related to the IOP level and fluctuation. So I think in most clinical practices, it is the pressure and the tolerance to medication which drives decisions for trabeculectomy rather than just the fields alone. It dampens fluctuation and reduces the rate. That's evidence. May be related to enhanced choroidal circulation, but even after surgery, patients with IOP on the higher side may continue to progress. So please keep a watch on that, and continuous monitoring, I think, is the key to monitor and preserve vision. Thank you.
Thank you, Shushmita, and thank you also for the study that you shared with us. I'm sure that we would like to come back to it later on. And I'd like to invite Dr. Pradeep Vyas. And Pradeep is going to tell us that he operated because the intraocular pressure was too high in his patients.
Good afternoon, friends. Thanks, Dr. Vinay, for having given me this opportunity. You want me to speak on I did the surgery because the pressure was too high. Dr. Sushmita and Dr. Pandav, both of them, they have said so. So I don't think that I need to say anything, but what I understand is that the glaucoma is a disease of intraocular pressure. Okay, I would not go into the detail of the glaucoma definition, which has changed over a period of time, but still the common understanding is that the glaucoma is a disease of intraocular pressure, and the objective of therapy is to lower down the intraocular pressure. The mainstay in the treatment for glaucoma is obviously a medical therapy. But when we say that the mainstay of treatment is the medical therapy, that basically is for that cohort of a patient who has a primary open-angle glaucoma. But we have a mixed cohort of the patients who have a primary open-angle glaucoma, the angle closer glaucoma, and the secondary glaucomas. And very small cohort who has a normal tension glaucoma. So obviously, I can say that the mainstay of therapy is a medical therapy in that group of a patient who has a primary open-angle glaucoma and the normal tension glaucoma. But the patient who has an angle closer glaucoma and the secondary angle closer glaucoma, usually they have a very high intraocular pressure at the presentation. Not only these patients, even the patient who has a primary open-angle glaucoma, in the advanced stages of glaucoma, they have a very high intraocular pressure in spite of the maximum tolerated medical therapy. So we have a group who has a primary open-angle glaucoma on a maximum tolerated medical therapy, still have a very high intraocular pressure. You have another group of patients who have an acute angle closer or a chronic angle closer disease, have a very high intraocular pressure. You have another group of patients who have a secondary glaucoma. They also have a very high intraocular pressure. And we want to lower the intraocular pressure in all these patients. So the mainstay of the treatment in all these patients would be a surgery. Why we want to lower the intraocular pressure? Why they want immediate attention? Because the vascular occlusion is pretty common after acute elevation of IOP. Patient usually remains symptomatic. They have a headache, they have a vomiting, they have an eye ache. So obviously you want to relieve them from the symptoms, and acute elevation of IOP causes irreversible visual function loss very fast as compared to those patients who has a normal tension glaucoma and the primary open-angle glaucoma. So for all these reasons, they need acute immediate attention, and we have to lower down the intraocular pressure. By what means you can lower down the intraocular pressure? Most of these patients, they need intravenous mannitol or other hyperosmotic agent, systemic carbonic anhydrase inhibitor, and all of us knows this, these medicines, they have their own problems. The patient cannot tolerate them for very long time. So obviously, they are not the permanent solution. So what should I do to lower the intraocular pressure? First, I will find out the cause why they have a very high intraocular pressure. And obviously, my immediate objective is to lower the intraocular pressure immediately, and I would use any means in my armamentarium, whether it's a hyperosmotic agent or systemic carbonic anhydrase inhibitor, so on and so forth. But still, everything fails, then I do not have any other option except to do the surgery. These are the conditions usually which present with a very high intraocular pressure: the acute angle closure disease, the lens-induced glaucoma, the pseudoexfoliation, pigmentary dispersion syndrome, traumatic glaucomas, post-surgical glaucomas, that is mostly the post-VR surgery glaucomas, the uveitic glaucomas, and the aqueous misdirection. And all of them, they need surgery. Most of them, they need surgery, not necessarily the trabeculectomy, because some other surgery also may cure them or may relieve the intraocular pressure. If you have a patient with acute angle closure disease, then what is the management? First, you have to bring down the intraocular pressure with the best possible treatment in your armamentarium, and you have to give the IV mannitol, you have to give the systemic carbonic anhydrase inhibitor, create the meiosis by instilling the pilocarpine frequently, and do the YAG iridotomy. And believe me, many of these patients, they do well for a very long time, and they are just okay with the medical therapy itself, and they do not require any surgical intervention. But what about this? When the patient has a traumatic high intraocular pressure because of the trauma, the angle recession. First, if you have a patient with the immediate history of trauma, with the hyphema, then probably you would like to drain the hyphema to lower down the intraocular pressure. Professor Ramanjit is sitting in the crowd, and she has published a paper where she has recommended that you do a trabeculectomy as early as possible to reduce the intraocular pressure. But still, if they require immediate surgical intervention, then probably you would try to drain the hyphema and bring down the intraocular pressure. But if there is a huge angle recession and over a period of time you are not able to control the intraocular pressure, then you do not have any other option except to do the surgical intervention, and that is the trabeculectomy. Another condition is a pigmentary dispersion syndrome, where you find the patients with a very high intraocular pressure. And if the patient has a pigmentary dispersion syndrome and present to you with a very high intraocular pressure, then probably it could be an inverse glaucoma, and you would like to do the peripheral iridotomy. And some of the patient may do well, but over a period of time, because of the lots of deposition of the pigments in the trabecular meshwork, the pressure remains high, and you would like to do a surgical intervention, and that is obviously in the form of the trabeculectomy. Another condition which is pretty common in our country is the pseudoexfoliation. And there also you would like to do a surgical intervention, because it is very difficult to control the intraocular pressure with the medication in a patient having a pseudoexfoliation. The other condition is a steroid-induced glaucoma. Many of these patients, for some or the other reasons, they need steroid therapy for a very long period of time. The systemic steroid is needed in a patient who has undergone the renal transplant, who has a chronic bronchial asthma, is not controlled with the medication. Some of them, they have some skin disease or some other systemic problem, myasthenia gravis, and so on and so forth, for which they need systemic steroid. Many of the patients that need steroid for some ocular condition like Ozurdex implant, for the patient who has a chronic diabetic macular edema, and if they are a steroid responder, then they have an elevated IOP, and the IOP goes up very high and remains very high for a very long period of time, and where you are not able to control the intraocular pressure by means of the medical therapy, then you do not have any other option except to do a surgery in these patients. Another commonly encountered condition with a very high intraocular pressure is a lens-induced glaucoma. It could be a phacomorphic glaucoma or a phacolytic glaucoma, and you have to control the intraocular pressure as early as possible, because the presenting IOP is very high, maybe in 40, 50, or even higher. And what treatment you would institute? Obviously, you would control the intraocular pressure and the inflammation with the medical therapy, but eventually you have to take out the lens. And many of these patients would do good after removal of the lens, but many of these patients may need treatment and may need treatment in the form of surgery following the removal of the lens. There is another condition probably which would not require surgery, though the patients may present to you with a very high intraocular syndrome, and that is very high intraocular pressure, and that is the PS syndrome, the Postural-Schwarzman syndrome, or this condition where you have capies, you have inflammation in the entry chamber. Patient present to you with a 40, 50 millimeter of mercury intraocular pressure. You treat medically, and these patients, they do well with the medical treatment. You have to treat these patients with a topical steroid or the NSAID and bring down the intraocular pressure as early as possible. And once that acute attack of the uveitis is over, then the pressure goes down, and it does not go up until and unless they develop or they come with the recurrence of the attack. Another condition is the spherophakia, where if you have these kinds of inverse glaucoma, then you do not have any other option except to remove this lens as early as possible, because these patients cannot tolerate the high intraocular pressure. Another condition is the iridocorneal endothelial syndrome, where the patients present with a very high intraocular pressure, and probably the surgery is the cure, where either you have to implant the valves or maybe a mini shunt, because the trabeculectomy may fail often in these patients, but they require immediate attention for very high intraocular pressure. Another condition is the aqueous misdirection syndrome, or what is unfortunately called as a malignant glaucoma as well. These patients obviously require the immediate attention, and you have to reduce the intraocular pressure by medical means. You just give the cycloplegic medication, that is the topical atropine. Many of these patients may do well, but if the attack is not broken, then you may have to do the surgical intervention, not necessarily in the form of anti-glaucoma surgery, but maybe the anterior vitrectomy or extensive vitrectomy, where you remove the adhesion of the vitreous even from the ciliary body region to reverse the aqueous misdirection. So if we talk of the indication of the surgery, all of us agrees to that the first and the most common indication of the surgery for a patient who has a high intraocular pressure, and then all other indications come subsequently. So obviously, the goal of the therapy is to bring down the intraocular pressure and try to preserve the vision of the patient. So trabeculectomy or any other glaucoma surgery could be the answer, except in a few conditions. So thank you very much for your patience hearing.
Thank you, Dr. Pati, for excellent presentation. And next talk is by Dr. Vinay Nangia. Dr. Nangia.
Good afternoon, everyone. I'm going to take you through this talk on when we operate because there's progressive disc damage and retinal nerve fiber layer loss. When there is progressive damage to the optic disc, the question that often arises is, am I going to operate or am I not going to operate? And that tells you that there is still a debate even if you see progressive damage, actually. What guides our decision to treat and how? Is it simply the retinal nerve fiber layer loss or disc damage, or do we consider several other parameters at the time of taking this decision, actually? So I'm going to take you through a series of case presentations, and the first presentation is on a lady, 68-year-old lady doctor. She presented with primary open-angle glaucoma and was treated with prostaglandins and beta blockers in 2011. She underwent trabeculectomy in the left eye in 2012, followed by cataract surgery again in the left eye in 2014. And in 2017, The right eye intraocular pressure is 16 millimeters of mercury on prostaglandins and beta blockers, and the left eye, it is 9 millimeters of mercury. And you can take a look at the photographs of the disc. This is from 2011, and this is from 2017, and again from 2011 and 2017, and there was a disc hemorrhage here actually. So we have a duration of follow-up of about 6 years. And this is the retinal nerve fiber layer, and I'm just showing these photographs in all the cases to tell you that we need to look at the retinal nerve fiber layer tissue every time we assess the retinal nerve fiber layer, not merely just the red, green, and yellow shades in this figure, because it tells you about the segmentation errors, and there are lots of causes of segmentation errors and presence of epiretinal membranes that tend to distort and increase the retinal nerve fiber layer thickness actually. So this is the trend report that we get, and this here is the global, and you can see that the line is somewhat flat. This is the temporosuperior in the right eye, and this is the temporoinferior. So we have a 73 years lady doctor. She has an intraocular pressure of 16 millimeters of mercury. There's a relative thinned retinal nerve fiber layer, as I showed you in the previous photograph. She has a loss of about 2.5 microns per year. She has vitreomacular traction in this eye, and the question is, should we operate or wait? And a significant portion of the decision has to be made together between the patient and us actually. And this is the left eye, and you can see the trend here. The trend here in the temporosuperior quadrant is showing as if the retinal nerve fiber layer thickness is increasing, but that's because of the presence of an epiretinal membrane. This is another doctor who presented with primary open-angle glaucoma in 2008, underwent combined surgery in 2009 in both eyes. Since then has been using beta blockers in both eyes. When last seen in 2017, intraocular pressure was 16 millimeters of mercury in both eyes actually. So this is a photograph from 2009, I guess, and this is 2017. And the right eye, we barely managed to make out that there was some loss here in the superotemporal neuroretinal rim. The left eye did not show any significant loss, although the color of the photograph is a little different because we changed the model of the fundus camera actually. So we have a follow-up of almost 9 years. And this is the appearance of the retinal nerve fiber layer in the right eye and in the left eye. And this is the trend report. This is global. It's not showing any significant decrease. The temporosuperior is showing loss of retinal nerve fiber layer. And so in the right eye, are we going to operate? She's 76 years. She's retired doctor and dean of the medical school. She has significant retinal nerve fiber layer still present. The quality of life is very high. The loss is at about 1.7 microns per year, and that's still very safe. And the loss is taking place mainly in temporosuperior quadrant and temporoinferior quadrant, and the temporal segments are still okay. So that means there is still a lot of buffer that's present for the retinal nerve fiber layer, and we don't need to rush into making any hasty decision. This is a case report of a 56-year-old male with an intraocular pressure of 22 and 23 millimeters of mercury in the right and left eye. He presented to us in January 2016 with the right superior hemispheric vein occlusion, treated with anti-VEGFs and beta blockers, and the intraocular pressure when last seen on beta blocker also in January 2017 was 22 millimeters of mercury in both eyes. And this is the right eye. You can see the collaterals here, and this is the left eye, and you can see that there is inferior neuroretinal rim loss. And this is the retinal nerve fiber layer in the right eye. Remember that there was significant thickening of the retinal nerve fiber layer here because of the venous occlusion, and this is the left eye. And you can see the loss both in the superotemporal and inferotemporal quadrants. And this is the right eye, and of course there was significant loss of retinal nerve fiber layer inferiorly and also superiorly because of the reduction of the retinal edema following anti-VEGFs. And this is the left eye actually. The left eye temporoinferiorly showed very significant loss of retinal nerve fiber layer just over 1 year actually. So should we operate? No, I think first we might wish to increase the medical treatment. There has been very rapid progression in the loss of retinal nerve fiber layer over 1 year. That's somewhat unusual. Could be because the patient is getting peaks of intraocular pressure, so we need to reset the target pressure. We need to follow up. If after increasing medications, the rapid loss of retinal nerve fibrillary still continues, then there is a question of considering surgery for this patient actually. We have a 49-year-old female presented in 2007 with primary open-angle glaucoma and an intraocular pressure of 22 millimeters of mercury in right and left eye. She was using prostaglandins, beta blockers, and alpha agonists. Trabeculectomy was done in the right eye in 2016 and in the left eye also in 2016 actually. And on looking at the optic disc photographs, from the first optic disc to the last optic disc photograph, there was a suspicion of neuroretinal rim loss here superiorly, and this is the latest photograph which shows a disc hemorrhage. The left eye, we couldn't make out any neuroretinal rim loss. We have a duration of follow-up of almost 10 years actually. This is the retinal nerve fiber layer in the right eye, and this is the retinal nerve fiber layer in the left eye. This is the right eye, and you can see that there's significant temporosuperior retinal nerve fiber layer loss, and of course we have already operated on the patient considering that. And here you have loss both globally, temporoinferior as well as temporosuperior actually. This is another case. We saw this patient in 2011 at the age of 50 years with a myopia of -6 diopters, intraocular pressure of 14 millimeters of mercury using beta blockers and carbonic anhydrase inhibitors. Last seen in February 2016 with an intraocular pressure of 15 and 60 millimeters of mercury in the right and left eye. She was still using prostaglandins actually. And this is the appearance of the optic disc then and now in the right and the left eye, and the optic disc appearance doesn't seem to have changed over a follow-up period of 6 years. This is how her retinal nerve fiber layer is now in the right eye and in the left eye. When she first came initially, I wondered whether this was glaucoma. The duration of follow-up shows that there has been some global decrease in the retinal nerve fiber layer in the right eye, but you can't actually see the classic progression that you'd like to see in the temporosuperior and temporoinferior quadrants in such a patient. In the left eye, all sectors show some decrease. It's not rapid, it's not so significant, but it's obvious, it's visible. The pressure is 15 and 16 millimeters of mercury on prostaglandins. That means that the baseline pressure would be 21, 22, 23 millimeters of mercury. The temporoinferior loss is more rapid compared to other sectors. She's intolerant to other medications. We have the option of following up. We have the option of doing laser trabeculoplasty, and we have the option of doing surgery. We haven't yet taken a decision in consultation with the patient, but we're still keeping the patient on follow-up. Thank you all very much.
Thank you, Vinay. I think documenting progression of optic discs and nerve fiber is quite challenging. But I think because you do need a very long-term follow-up for that, and you have done an excellent record keeping. Dr. Tanuj is not here actually, so I think Dr. Vinay is doing the next talk also. I operated because the previous surgery failed.
If I go over time, you're welcome to just let me know actually. We need some time for discussion. So I'm going to talk to you on, did I operate because the previous surgery failed? When we have a trabeculectomy failure, what do we do actually? And there are some principles of management of trabeculectomy failure that we need to adhere to. One is, of course, that we may wish to restart medical treatment. We may wish to consider revision surgery. And in revision surgery, it could be a revision trabeculectomy or it could be a glaucoma implant. You could, of course, also consider laser trabeculoplasty or laser cyclodestructive procedures actually. Sometimes we also resort to bleb needling. And if medical therapy works with less medicines than before, then you may still be a winner and you may not need to reoperate actually. You may revise the same trabeculectomy or use an adjacent site. And of course, as I mentioned in the earlier slide, a glaucoma implant may be considered. So I'm going to take you through a few case studies that tells you the dilemma that we go through when we have surgical failures actually. This is a 45 years female. She has a myopia of -3 diopters in both eyes and underwent surgery without the use of mitomycin C. She's on maximal medical treatment now with intraocular pressure of 19 millimeters of mercury and significantly cupped discs actually. The post-op period, the right eye intraocular pressure was well controlled as also the left eye, but now 2 years later, the intraocular pressure is 22 and 19 millimeters of mercury on maximal medical therapy actually. And this is what the photographs show. She's a myope, so there is significant optic disc cupping. And this is the retinal nerve fiber layer. You can see that the retinal nerve fiber layer loss is significant. And what bothers us really when we're looking at the retinal nerve fiber layer is to take a look at the retinal nerve fiber layer in the temporal segment, because there's a flooring effect also in the temporal segment. But once you reach a certain level of retinal nerve fiber layer loss in the temporal segment, then the vision starts to drop after that. So you'll have 6/6 vision at a certain level. After that, it tends to drop. And that's the huge dilemma that we face here. So this is in 2015. You can see the appearance of the bleb. And this is 2016. You can see that somehow the vessels have started encroaching. And you can see that the appearance of the bleb has changed, actually. So what's the challenge of surgery? What site are we going to reoperate? There is an adjacent spillover fibrosis that we can see here. She has myopia, and there is significant progressive vascularization over the last 1 year, actually. There is a late development of the ring of steel that we know of. There is a reduced area of pale bleb, and there is a possible reduction in the cystic appearance. So that's the change that has taken place over a period of 1 year. And I think a part of it I'm attributing to the medicines that we started for this patient. So this is the second case report. 71 years male, intraocular pressure was 20 millimeters of mercury and 12 millimeters of mercury in the right and left eye respectively. This patient underwent combined surgery in both eyes in 2015. By early February 2016, his trabeculectomy had already failed, actually. He was advised combined surgery in right eye and underwent the same in December 2016. In January 2017, his bleb was flat in the right eye and vascularized with an intraocular pressure of 16 millimeters of mercury, and he's been advised anti-glaucoma medication in both eyes, actually. And that's the appearance of the optic disc then and now. And you can see here the retinal nerve fiber loss in ferrotemporal. The left eye retinal nerve fiber layer is still looking quite good, actually. So we've created a new term, and it just came out of nowhere, and we started calling this apical vascularization and fibrosis, because it's there right around the area where we created the scleral flap, actually. And this is very, very classical in the bleb failures that we see. So it's recent surgery. We perhaps still need some time to work things out. Needling is unlikely to work because of the apical fibrosis. And wait for the vascularization to subside, that is, put the patient on drops, let the vascularization subside a little bit more. Desist, if you can, possibly from giving prostaglandins, because I believe they perpetuate the vascularization that you see here, and start medications and take a decision for a little while later, actually. This is a male patient, 46 years, with primary angle closure glaucoma and near total cupping in both eyes. She's on prostaglandins and beta blockers with an intraocular pressure of 33 millimeters of mercury. Right and left eye underwent combined surgery in October 2016. By November 2016, intraocular pressure was 25 and 28 millimeters of mercury in right and left eye. I think sometimes I feel whether this happens only to me or whether this happens to many more people. So on alpha agonists and beta blockers, the intraocular pressure has been reduced to 18 millimeters of mercury, actually. And this is what the bleb looks like, actually. So there's development of apical fibrosis and vascularization that's associated with significant optic disc technique, actually. So what are we going to do? It's either going to be a retrab or a valve implant. Whatever we do, there is a real threat of losing further vision, because the disc, when we started, was extremely cupped, actually. This is a challenging case of a 55-year female with high myopia, axial length of 28.8 and left eye 28.51, significantly cupped discs, intraocular pressure of about 20 millimeters of mercury on prostaglandins and beta blockers. She underwent a TRAB in December 2009 with use of minimal mitomycin, developed hypotony, treated with autologous blood injection, further kept on prostaglandins and beta blockers with intraocular pressure of right eye 13 and left eye 14. Left eye was extremely steroid sensitive. Remember that especially in myopes, when you are treating one eye following cataract surgery or trabeculectomy with steroids, always look out for a pressure rise in the contralateral eye, actually. Right eye underwent a cataract surgery in June 2016. The intraocular pressure gradually went up to 36 millimeters of mercury by December 2016. The right eye We thought we were going to reoperate and do a revision trabeculectomy, but she underwent bleb needling. And to my surprise, the bleb needling worked 7 years after the trabeculectomy had been done, actually. Just simply by breaking the adhesions. This is something that I didn't expect. The right eye intraocular pressure today is 6 millimeters of mercury. It appeared that it was very easy to do. I took the needle under the flap, lifted up the flap, went through the sclerostomy. Some fragments of the sclera actually fell into the anterior chamber, and they're still there. And a track was created so that fluid was seeping out, and the size of the bleb actually increased. And this is the appearance of the right eye. This is the appearance of the left eye, and you can see the struggle we're up against, actually. And this was the old bleb, and we created a track, and the track led the fluid to also reach up to this point, actually. And this is the white sclera that actually fell into the anterior chamber when we did the needling, actually. So why did we operate? High myope, significant optic disc cupping, significant retinal nerve fiber layer loss, not under control with medications. And what did we do? Needling, and to our surprise, it created a track that worked, actually. I think I'm going to stop here, and maybe we can have time for discussions. I think maybe start with some questions from the audience. And Pradeep, may I ask you to join? Okay, just to get the discussion going, let me go to Dr. Pandav's talk, actually. I think he alluded to what maximal medical therapy was in the patients that he was seeing, but really just to get everyone's concepts on the right path, actually, what according to you is maximal medical therapy?
I think something that patient can take, easily. That means he's not really inconvenienced too much. It could be sometimes just one drug, but by and large it would be like 2 drugs or 3 drugs. So if you're going beyond 3 drugs, then it is kind of becomes difficult to manage. Or anytime you need a systemic therapy. So anytime you start needing systemic therapy, that means you actually have crossed the limit of maximal medical therapy, and you have to look for an alternative. So some people tolerate multiple drugs, 4 drugs also. So in my practice, there will be many patients who are on 4 drugs because they they are okay with it. They can treat, and their pressures are in a range, or the disc is a kind of that there's no immediate danger for that. But anytime you're going to 3 or more, you are thinking in terms of that you have reached the limit of the therapy.
Thank you. I think the message that we are trying to get across is that sometimes just one single drop for a patient could be maximal medical therapy for that patient in that given situation, actually. So I think that's extremely important, actually. And then the next question that I had in mind was, what is the threshold? So you have a patient on maximal medical therapy. Do you have a threshold that if the pressure is 22 millimeters of mercury, then you're going to operate?
I think there's no one figure for that. It basically depends on the case, that is how advanced the disease is and how much the magnitude of the IOP is also. Like in my cases, I have shown in some of the secondary glaucomas, they tend to have very high pressures. So even if your visual fields are normal, your disc is pretty good, and the condition is such that it's unlikely to respond to medical therapy. So there you have a lower threshold for doing surgery, lower in terms of progression or in terms of the damage which is already there. But IOP is definitely high. But in terms of IOP, again, it depends on the advanced neuropathy, how much it is that. Like if you have 20 millimeters of mercury pressure, but your disc is very advanced disease and a patient is already on multiple drugs. So those are the patients who are at a risk of losing vision. So there your threshold for doing surgery would be much lower in terms of IOP.
Yes. Shushmita, you were alluding to a case that you felt that there was a dilemma in the patient that you mentioned to me with normal pressures, and you were. Would you like to recount your experience and your dilemma in thinking about that patient for everyone?
The one that I showed.
The one that you were speaking about between 15
this
and 16
is the one,
millimeters.
The one that I showed.
Yes.
That we weren't sure of the visual fields, but it kept progressing. And ultimately we did trab after struggling for a whole year. But he was somebody whose pressures were all right for his disc, and he had no problem with the medication. But the fields kept progressing, and then we did operate, and 1 year later, his GPS shows a progression again.
Again, okay.
So,
Okay.
but it's a very rare and uncommon thing for us to operate on somebody who is only having field progression, pressures okay for disc, tolerating medications, like 15, 17 pressures for an early glaucoma was all right. I would never have.
Yes.
But we were struggling with this field. So it's important to keep in mind that maybe the field's progression is something which you have to be very, very careful with before, sort of labeling. And interestingly, I'd also like to share that after the thesis on structural and functional progression, and she's written it up, and she's our senior resident now, and everything has been done. And when I asked her to take those patients out again, the 5 that had progressed, 4 of them had reverted.
Had reversed
Back. So, no, with nothing. So even in the ocular hypertension treatment study, there is an ancillary study to the OHTS with no drug company will talk about, in that 76% of the progressors in the OHTS reverted on a 4th field.
Yes.
So we have to be very, very careful labeling field progression, provided everything else remains all right. Disc is stable, pressure is all right, nothing else going on but field progression. So that niche of patient where you operate because of field progression, I would be very, very careful about.
Would you like to investigate systemically? The pressure is normal. Still the field
Let them finish and I'll have you ask. Just what?
The
you
OCT
can
was
forward
by
here for
and
my
large stable. There was nothing much going on in the OCT. There wasn't much change in that. But remember that even in the OHTS, which is non-glaucoma, there are cases where the visual field had progressed while the disc remained stable. So that situation does. It's more common for structural progression to precede visual field loss, but it is possible for visual field to progress and structurally you're not seeing anything. Remember, these are what you see. Maybe it's just the machine is just not picking up that change. That's all. The scenario of a visual field progressing with pressures which are okay for the disc and being tolerated on medications is very, very rare. It's a rare scenario. There could be an ischemic component to that which is not visible. And this is more common with normal tension glaucomas. Lower pressures are more likely to show up a field progression, so you need to be very careful with that. But what I was saying was completely different. Is the field actually progressing? Because if you do even 3 fields and your machine says VFI, yes, GPA, yes, you do a 4th and 5th field and they revert. And this is common. So be very careful before you label somebody as a field progressor, because we might unnecessarily intervene where actually no intervention is required. That's the thing.
Okay. May I have your question, please? Yeah.
Sir, 82-year-old patient, one-eyed, having cataract, for cataract surgery, and pressure is 16 millimeter. This is a little bit larger size, but it is 0.9, and there are field changes, advanced field changes. Should I do a combined surgery, only cataract surgery, or
Pressure?
16.
16.
On 3 drugs.
On 3 drugs.
1.6 on 3 drugs. But disc is 0.9.
0.9, and large is a little bit of
I think a combined would be warranted with a 0.9 cup.
Yeah, go
so
ahead.
I have a case. I have a lady of 78 years of age, and she has already lost one eye due to glaucoma. The other eye is having 624 vision with 0.9 CDR, and she is on 3 medications right now. But her physical condition are such that we cannot go for any perimetric investigations or even the glaucoma disc imaging. So she is always worried about, whether she will have the other eye problem with glaucoma or not. She comes every 6 months to me. I have 3-year follow-up almost. And when she came first to me, she had already lost one eye, but the other eye shows consistent 624 vision with similar, there is no optic nerve changes, right? But now what to do, whether we should continue same treatment onwards or...
I'll just ask you what's the age?
78.
78, and she can walk, she's mobile, she's healthy?
I mean, she is not much mobile. I mean, she comes to my clinic in wheelchair.
Does she have a cataract actually?
No, she operated both eyes, pseudophakic.
And she's 624 vision?
Yeah, 621 one eye and the other eye is lost due to glaucoma.
Yeah, so if you're treating the eye with 624 vision, and if she's already had a cataract surgery, then of course it means that the central field of vision is almost going actually. Okay. So the best thing to do is to try and see as best as you can control intraocular pressure.
Sorry, sir. My point is, since 3 years, the vision is stable, 624. The optic nerve, I mean, what we see on slit lamp and we take the images, they are almost same. There is no progression in that. And the IOP also, I mean, whenever she comes, the IOP ranges between 12 to 13 almost, 12, 14.
Okay.
With the same medications, there is no change in the IOP.
Yes.
So my worry is whether I should go and operate her or we should continue with the same treatment.
Don't go.
Because
I wouldn't operate.
Why she has got visual acuity of 624? What's the reason? If it's a glaucoma, then she has a pretty advanced glaucoma.
0.9 CDR. That's what I said. Almost.
Yeah, it's almost near total cupping.
Yes.
That is the reason.
But I could not get any visual fields till today.
See, if she has a pressure of 12, 14, 16, and she is on 3 drugs, and still she is progressing, then either you have to investigate her for systemic causes. That is there any other reason behind the progression? And
that is what I'm saying. Since 3 years, there are no, as such, parameters are not deteriorating.
Because remember one thing, if you take her for the surgery, then also you have to do aggressive post-operative follow-up for the patient. You cannot operate and forget about that. Okay. It's not that the surgery is 100% successful. It's not that, even in the early post-operative period, she may have IOP spike. You may have to do the massage or release the suture or do the sutural lysis and so on and so forth. So obviously the patient need immediate attention, and if you are operating, then also you don't think that you have just got away with the problem.
But sir, the only problem is, my problem is she is physically not very fit. Even, I could not get the diurnal variation because patient is one-eyed. Vision is 624 since 3 years. Yeah. Yes. So don't think of surgery. We can continue with the medical.
The cataract may be there, may be progressing, may be
Operated
cataract.
Have you ruled out any posterior segment pathology?
Yes, everything is fine. Everything else is fine. This one is normal.
Let us stay happy.
Thank you.
Okay. I want to go back to... go ahead, yeah.
If the patient is still progressing after a control with the medications, like suppose as you already showed the slides with the 13, 14 millimeter mercury, and we plan if the disease is still progressing. So what should be the target IOP after the surgery? We plan for the surgery like 14 millimeter mercury early teens with medications. After surgery, what should be the target IOP?
Those with lower pressures, the reason for progression is usually a fluctuation. And what surgery is going to do is dampen that. That's what literature tells us. But that's what, again, I'm making the same point. Be very, very sure that he is progressing. I mean, invest your time in doing a field 3 monthly. Glaucoma, fortunately, gives us that time. I'm sure if you do 3 I'm telling you, the one that I showed, I thought he was progressing because after 3 consistent visual fields, the machine tells me GPA, likely progression. And I operated. 1 year down the line, he still progresses. And I'm sure if I do it again, it'll revert. And it did. So in Jan, he progressed. Before coming to the conference, he's reverted. So be very sure of, like Dr. Pradeep said, look for systemic factors, do a carotid Doppler, look for other things. It may not be an IOP dependent thing. It might be ischemia. It might be something else which is going on, causing a functional progression. But doing visual fields and repeating them is step 1. do not take it at its thing.
You're right, ma'am. But then if there is any structural changes, if structural damages there happening even after control, even after the trabeculectomy done, what next can we go for?
If the pressure is controlled after trabeculectomy and you're still getting progressive, which is known to happen actually, you can get progressive optic disc damage after intraocular pressure control with medical treatment or even off medical treatment or even with following trabeculectomy, then you have to leave the patient alone. Besides following up, you may not be able to do too much.
Before that, you have to measure the diastolic blood pressure, as she said, the carotid Doppler, and sleep apnea, and some other relevant history like, chronic constipation. Or I had one patient, and when I asked history repeatedly, so he was a shunt blower. So he used to blow the shunt for half an hour every day in the morning. So you have to look for all those causes, and inadvertently with the patient is on steroid or something of that sort, the fluctuation, as she said, that is again very important thing.
Shushmita, I think we're going to be running out of time, and I just wanted to ask you about the very exciting study that you did actually, that roughly I calculated that, it's a simple question, I'm sure you have. Roughly I calculated that there was a pressure drop of 5.7 millimeters of mercury in these patients that you followed up over 9 years. So what was your... I was just thinking that, a lot of these patients came to you with very high intraocular pressure, and when they come with very high intraocular pressure, you tend to have discs that are already significantly cupped. Some of them also begin to show pallor, generalized pallor. And then these are the discs that even after reducing the intraocular pressure, you have a sense that the pallor is increasing and that the visual fields continue to deteriorate and there is some structural loss actually. But we didn't see that here actually.
Yes, that was it. I mean, that was the gratifying thing the question was, what is happening to the advanced glaucomas? I mean, we lose them in the crowds. So I asked her to look at only advanced glaucomas at presentation.
Yes.
But I realized what we are treating and which actually happens is the pressure. So the take home from this thesis at least is because our threshold was pressure, and 40% at presentation with advanced glaucomas, first modality of treatment we did was surgery. We didn't even go into the gamut of trying to bring it down because there were things like 34 pressures, 0.9 cups, nothing would work.
Yes.
So nearly half of them required surgery, and the heartening thing of the whole thing was at the end of a mean 9 years, from -20, it was a mean of just -21. So functionally, they do very well if they're just caught in time and the pressure is controlled. We're not looking so much at visual field progressions, and these were people who only had reliable baseline fields at presentation.
Yes.
We did not take the ones who could not do fields or were too advanced or too whatever. So the pressures came down, and they didn't. So the ones which have reasonable vision to do a field, if you catch them in time, I think it is heartening that we can, when we shouldn't give them up. But then 1/3 of them required second surgery. I mean, 1/5.
That's
40% first surgery. Of them, one quarter almost third surgery, and about 3% required a fourth or something else, a DLCP or whatever. So we have to keep on at them. That's all.
So I think it's, go ahead,
Don't give up on them too soon.
Just do an OCT and...
Okay, so this OCT business is good for early glaucomas, very early, and the non-glaucomas or something where you have enough RNFL to document change. Once you have advanced glaucomas, believe you me, there is Dr. Ramanjit's paper in the IOVS where they took no PLIs and they did RNFL and they still have 40 microns. So when you're down to an RNFL thickness of 50-55 microns, believe me, the machine is not going to pick up change. And sometimes the change is only functional. So don't give up on them. They don't have a 10-2, go for a macular threshold, look at sensitivities, and give them your time. Before you label, somebody cannot do a visual field. It's a very rare person who cannot do a visual field. Children can do it. So don't give up on them early enough. If you don't have anything, One modality you have is imaging, but please keep in mind in advanced glaucomas, imaging will not show change. Imaging will show change after visual field shows change in advanced glaucomas. So you need to keep that in mind.
Okay.
Yeah. With a 0.9 cup, there's no point doing anything else. You write there, 10-2 fields both eyes. Even the 10-2 is going to be 3/4 gone. So the advanced glaucomas are like that.
Are the retina guys here to learn glaucoma? Is that correct? Okay, well. Thank you all very much.
It's called solidarity.
It's a pleasure having all of you here. Yeah.